Good afternoon. Good afternoon, everyone. We're just waiting a few moments as our many attendees log on. We will start momentarily. Thank you for your patience. Good afternoon, everyone. You're all very welcome this afternoon to our Sláintecare webinar. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement Forum, and I'm delighted you've joined us for today's webinar, the 16th Sláintecare webinar, part of our Learning Network event series. As always, we are happy to take questions or comments from you, the viewers. Please use the chat function and I will convey your remarks to the panel of guests with us this afternoon. Sláintecare is about the right care in the right place at the right time by the right team, but it's also fundamentally about doing all of these things with quality and patient outcomes in mind. We have a packed agenda for you this afternoon. We've 8 projects who have been engaged in quality improvement activity as part of the Royal College of Physicians Diploma in Leadership and Quality in Healthcare and the RCPI CHO Collaborative. The RCPI programme is a 10-month learning programme funded by HSE Quality and Patient Safety, and it is free to access for HSE employees. During 2020 and 2021, the participants on the programme were mainly from teams from the community health networks and healthcare organisations across Ireland. The RCPI CHO Collaborative ran a short-term quality improvement programme in 2021 with 8 teams. Each team was asked to bring a quality problem in their workplace and to seek to implement a sustainable improvement project solution using the methods, approaches, and processes identified in the programme. The projects you'll hear about this afternoon show how the Diploma programme and the CHO Collaborative are successfully implementing change and enhancing quality. But before meeting the first of our 3 projects this afternoon, I am delighted to be joined by Dr. John Brennan. John is a GP and quality improvement expert in the Royal College of Physicians in Ireland. John, you are very welcome to our joint webinar this afternoon. Delighted to have you with us.
Hi, Gráinne. It's wonderful to be here, and thanks very much to you and everyone at Sláintecare for their kind invitation to share this work.
No, it's great work. Thank you. So, John, maybe to start us off with, what is quality improvement?
Well, I suppose, Gráinne, that's a term that takes a little bit of unpacking. I mean, the concept of quality in healthcare can be a pretty complex one. So I suppose first, how we try to kind of distill or define quality in healthcare is through sort of 7 different domains. High quality healthcare, we believe, is safe, it's timely, it's effective, it's efficient, it's equitable, it's sustainable, and it's person-centered. And in the projects you'll see over the course of the afternoon, you're going to see those areas of quality are the places where people have been choosing to put their effort and their work. When you add that improvement term after it, quality improvement, I suppose that can mean lots of things to lots of different people. In essence, it recognizes that everyone working in healthcare today wants to do a great job for their patients and their fellow professionals, but they also want to find ways of doing it better all the time for themselves and for others. The kind of research definition of quality improvement is the combined and unceasing efforts of everyone in healthcare. That's patients, providers, planners, payers, researchers, educators, everyone, to make the changes that will lead to better health or outcomes, better system performance or care, and better learning, growth, and professional development.
Very good. So when you were planning this program, how were you planning it would work to really raise the bar around quality improvement?
Yeah, so I suppose that the kind of key to the program is that it's practically oriented around kind of the realities, the real world challenges that clinicians face in working with patients to produce improvement in quality. So we can't hit a reset button on the whole system and start from scratch. We have to work with what we've got and build improvements that fit with the context and, as we said, the realities that people face every day. The programs we run, focus, I suppose, on kind of core theories and practical tools of systems understanding, of variation, statistical thinking, and measurement for quality, of the core concepts around the psychology of change, and then also the principles of design thinking. So having a hypothesis, testing changes in the real world to see if they work or not, and focusing on the learning that comes from those tests all the time. So in the projects you'll see, in the next few minutes, you're going to see that measurement. You're going to see these tests of change. You're going to see changes informed by deep and broad understanding of how the system works, the people, the processes, the tools, the equipment, the environment, I suppose the external drivers of what determines what we do and when we do it. So I'm really excited to be here and to kind of once again enjoy all this great work that these teams have been doing.
Yeah, well said. And I think a great introduction to the first round of projects that we're going to look at. And I think people will be able to look out for some of those characteristics that you explained to us. And also this idea of, piloting and testing. Having a theory is one thing, but seeing how it works in reality and how do people who are either the subjects of it or the implementers of it, how do they feel it's going for them? And we see that thread running through of people really looking at the various stakeholders and being informed by the lived experience. So great stuff. So thank you very much, Dr. Brennan. We look forward to speaking to you again as part of the final panel session later this afternoon. Our first set of videos for you are all on the theme of improving with others. Community Healthcare East have worked in the physiotherapy field to improve referral pathways. Community Healthcare West have worked on risk notification. And Ballymon Community Healthcare Network in CHO 9 have worked on improving early identification and management of frail older adults at risk of sarcopenia and reduced mobility. But first, let's hear from Joanna O'Neill in the field of physiotherapy, and then we'll go straight to Siobhan Jordan on risk notification. And finally, we'll have the video from Caroline Lawson and their work in Ballymon with frail older adults.
Afternoon, this is a presentation on the Physiotherapy Referral Pathway Project run by Evan Flavin, Physiotherapy Manager, and myself, Joanna O'Neill, Network Manager, working with the RCPI CHO Collaborative. So there was an audit carried out of the referral pathway for physiotherapy due to a patient who had to be readmitted to hospital because there was a delay in the referral being received by the physio department in Dublin South East. The audit showed a real risk of error due to multiple referral modes, process delays, a lack of transparency and accountability. So the aim was to streamline the email referral process by improving the reliability of the core data set from 60 to 19% of all email referrals received. As you can see here on the run chart, the number of referrals coming via email in the initial stages were incredibly low. And then the data set information was only 60% accurate. So the aim was to reach 90% accuracy and improve the numbers of referrals coming via email. This was done by setting up champions within the hospitals and the primary care team settings to educate and encourage the use of the email referral pathway and to assist with any issues. We also made use of surveys and feedback from the teams for ideas to reduce barriers to the use of the email. We used the phase rollout. So we began with the acute hospitals, then we moved this on to the primary care team and finally the GPs. As you can see, by December 2020, the number of referrals coming via email had increased and the accuracy was up to 98%. In January of 2021, then we had the COVID spike, which saw an even greater increase in referrals. And the accuracy again went up to 99%. Unfortunately, last summer there was the cyber attack, but this was then used as a benefit to regroup and recoup and review the process. And again, by September, October of last year, the referrals were almost back to pre-cyber attack numbers via the email, and the accuracy was up to 99%. The main benefit of this has been to the patient, who is going to be seen in a much more timely manner because the referral is received immediately, the accuracy of the data set can be checked, it can immediately be sent back where necessary, and re-referred straight away so that the patient can be seen as soon as possible. The further benefits have been improved communication with the MDT and an opportunity to engage in feedback and education sessions between the different services to encourage greater communication and open communication. The benefit of the referral pathway means that there is a way of tracing referrals, so we can check very simply and easily if it's been received, if it's correct, and how long someone would be waiting to be seen. Many thanks.
Hello everyone, welcome to the Community Healthcare West QI Collaborative. My name is Siobhan Jordan and I'm one of the team members. The remaining team members consist of Emma Nyochton, Ger Kilkelly and Donal O'Grady. We work as part of the Quality and Patient Safety Department in Community Healthcare West, which includes the counties of Galway, Mayo and Roscommon. Our QI Collaborative project was based on the risk management notification process in our primary care division. Let me give you a background as to how we selected our project. We had identified a very high number of risks on the primary care risk register, resulting in an unyieldy and difficult to manage process. If this was not addressed, it could have led to harm to a patient or staff member, as risks were not being managed and reviewed in an effective and timely way. We identified key stakeholders and obtained commitment from them to address this issue by developing a specific project, and working in collaboration with these stakeholders, we developed a specific problem statement. This was an inefficient and ineffective risk management process as a result of not having a usable risk notification process. Through the use of quality improvement tools, such as driver diagrams and the PDSA cycle, we then developed and refined a SMART aim statement: specific, measurable, achievable, realistic, and time-bound. We aimed to improve the efficiency and effectiveness of the risk notification and governance process and reduce the number of risks on the primary care risk register by 50% by the 31st of October 2021. The backdrop to this was to make care safer by ensuring that risks were being assessed and monitored effectively. The number of risks on the risk register had grown from 20 risks to 133 over time due to the lack of a robust risk notification and screening process. This led to the development of a new risk notification process in primary care. You can see here from our run chart that there were a number of key activities that enabled us to achieve our aim. In order to identify these, we completed a number of iterations of a driver diagram to identify our primary and secondary drivers. The primary drivers included education for key stakeholders, governance and leadership, measurement and administration of the risk register, and the resulting secondary drivers such as training, completion of a baseline audit of the register, clarification of resources and roles, and the development of an algorithm to outline the new risk notification process. We refined these drivers using a number of PDSA cycles. As you can see here, the key activities areas noted in the reduction of the risks are the use and introduction of a new screening process, the review and streamlining of existing risks to eliminate duplication, and de-escalation of certain risks to general managers and head of discipline risk registers enabled us to achieve our aim. This is illustrated in the run chart by the reduction in the number of risks on the primary care risk register from 133 in April 21 to 75 at the end of October, start of November 2021. This improvement has since continued, and there has been a further reduction in the number of risks on the primary care risk register. How we achieved all this and our collaboration was we worked with the key stakeholders in primary care to test and change the existing risk register template and associated processes, and we also provided education sessions on the management of risk registers and risk notifications. They were then able to see the benefit in implementing changes to provide a more effective and efficient risk register with improved governance, the overall objective being enabling a reduction of avoidable harm. As a summary of our project, we developed a newspaper article entitled "Risky Business Avoided" to illustrate our project. Thank you, and we welcome your questions.
Hello, my name is Caroline Lawson and I'd like to present some information on a quality improvement project which I carried out with my colleagues Catherine Devaney and Sheena Rafferty, who work alongside me in the primary care services in Ballymun Community Healthcare Network. So for our project, the identified problem which we chose to address within the service was that currently there was no screening or pathway of care for older adults who were presenting with sarcopenia. Sarcopenia has been defined as an age-related involuntary loss of skeletal muscle mass and strength. It is the one key cause of functional decline and loss of independence in older adults. So the aim of our project was to introduce an interdisciplinary care pathway within the physiotherapy and dietetic services in the Ballymun Community Healthcare Network to support the early identification of clients at risk of frailty, supporting them to maintain their independence and functional abilities within their home setting, and helping to reduce hospital admissions. So the normal waiting times for dietetic services would be somewhere between 12 to 24 weeks, but the clients involved in the project were prioritised and waiting times for them were between 3 to 12 weeks. The SARC-F screening did impact on dietetic referral numbers as clients were being identified as requiring a nutritional screen who previously wouldn't have been identified. The increased referral numbers to dietetics from 2 per annum in 2020 to 13 within the 2-month period illustrates the benefit of a screen and pathway for this condition and how it assisted in identifying clients requiring this input. A person-centred approach was an essential component of the project. So throughout the design and production phases, engagement with clients, staff and relevant stakeholders was important. Feedback was taken on board and reviewed through the use of a PDSA form. Semi-structured interviews were held with clients who received a service through the new pathway. When asked whether they would be interested in receiving physiotherapy and dietetics intervention, the responses were positive, with clients stating, yes, for both, they are the experts, I think they could motivate me and support me. Yes, exercise classes with other people rather than just doing instructions myself. Or a dietitian, yes, to put on weight. In addition to this, a focus group was undertaken with the primary care, physiotherapy and dietetic staff who participated in the project. So in total, we had 4 staff members who participated in the focus group, 3 physiotherapists and 1 dietitian. the themes which were identified from the focus group included benefits such as enhanced interdisciplinary working, a greater focus on person-centred care, and enhanced quality of service provision. So just this slide outlines some of the responses the staff involved in the focus group gave. So including from the client's point of view, I see they get maximum benefit. We're providing a joint service for the client, very close together from a time point of view. A great collaboration between physiotherapy and dietetics. So some challenges also noted by staff included a lack of staff resourcing and the impact which waiting lists had on the ability to carry out timely interdisciplinary working. And in addition to the focus group and client interviews, the project team engaged with key stakeholders locally within the CHO so as to ensure the project was reflective of current local needs and working collaboratively with the existing services for older adults in the area. So thank you for listening to our presentation. And now if you have any questions, my colleagues will be available to answer.
Super presentations. Thank you so much for presenting those. We're going to go into our first panel conversation, if we could now. So I'd like to welcome Evelyn Flavin, Physiotherapy Manager with CHO East. Evelyn, you're very welcome. Emma Nocton, Quality and Patient Safety Manager with Community Healthcare West. And Catherine Devaney from the programme that we've just heard from there, Clinical Advisor to older persons. Thank you to each of you for sharing the QI work you are all engaged in. Could I go to each of you first of all and ask you, how did the use of a structured quality improvement approach help you when you were working out this change process with your team and indeed with others? Evelyn, can I come to you first?
Yes, well, firstly, our audit showed 40% error in referral accuracy, which really engaged our stakeholders. They had real concern that this caused a delay in service to our clients. We all agreed we needed to do something about it. The run chart demonstrates the improvement. The hiccups during January 21 COVID surge and the cyber attack, and yet.
Sorry, Evelyn, we're losing you there.
To a 99% physios. Can you hear me?
We're losing you. Go on ahead, but if it continues, we might go on to somebody else and see if you can improve your connection.
And finally, the monkey survey with 2 stakeholders found out the barriers and also that stakeholders found the solutions. We made the changes, we gave educational updates and completed another survey and face-to-face meetings. And the stakeholders felt they were listened to and we co-produced solutions.
Great, thanks Evelyn. And for Emma, again, same question to you. How did you use this structured quality improvement approach? How did it help you when you were working out the changes you were looking to implement?
Thank you, Grania. I think what really helped us was in terms of trying to narrow down what our original problem was. So using, I suppose, diagrams to develop our aim statement and using PDSA cycles to kind of do several reiterations of it while going back to key stakeholders to identify where we're getting to the real root of the problem was really key for us. And I think that's what really, really helped. And I think a combination of using those tools is what really narrowed down the focus and enabled us to have a really smart and defined aim statement compared to what we originally started off with. It was a major problem with, we weren't really sure where to start with. So we found the use of the quality improvement tools and techniques to be really beneficial.
So being able to really focus on, rather than looking at 50 things, what is the one thing you want to, okay, that's very interesting. Thank you for that, Emma. And Catherine, for you, same thing, structured quality improvement approach. How did it help the work you were doing?
I think it was really important for us, like working on the aim statement and kind of ensuring our goals were smart, that we were able to identify a quality improvement project that was kind of relevant to high risk clients referred both to physiotherapy and dietetics. And also that was relevant to, I suppose, the local population. stakeholder engagement was essential. Like, I suppose this project was carried out during COVID restrictions. So engaging with physios and dietetics ensured that we were able to kind of bring about this project in a way that was sustainable, and that we could kind of carry it out for the 2 months. And obviously kind of, I mean, also kind of wider stakeholder engagement was really important, because it also highlighted further opportunities for service improvement in the provision of kind of services for older persons. So we identified a further opportunity to work with the home support services. So kind of that was really essential.
Yeah. And Catherine, a particular question has come in as a result of the project video there. And somebody has sent in a question: how are these older adults who are already identified via DEXA scan to have both osteoporosis and osteopenia by GP and private consultants in the CHO9 group, how are they to get on to the pathway, and asked if exercise paths, at the moment there's no such service being offered to over 70s. It's a very particular question.
Well, I mean, I suppose for this pathway is for kind of sarcopenia. So we already screened all clients who were referred to our service over the age of 65 for falls.
Okay.
And then we kind of added on this additional SARC-F screen. So that was really essential then, because obviously physiotherapy and dietetics are two of the key components for the management of sarcopenia. So actually, we actually screen all clients for osteoporosis, but they wouldn't necessarily, I suppose that was a younger cohort, and they wouldn't necessarily be kind of referred on to the SARC-F.
Great stuff. Yeah, great. Okay, thank you. And could I ask the three of you then, in reflecting, you know, the biggest learning for you in applying learning from the program, either personally or as part of your team? What was the biggest learning when you think back on the experience? Evelyn, we come back to you.
Well, I know, well, I've always thought quality improvement is part of our job, and the use of the HSE quality improvement toolbox makes that happen. It makes it easier and really focuses you. And ultimately that really improves the service to our clients. And that's what it's all about. Okay, so you have always thought that, but this really reinforced that for you. Thanks, Evelyn. Emma, same question to you.
I think for us to be able to demonstrate that actually an improvement did occur by using kind of proper QI tools was a big, important piece of work for our key stakeholders. You know, using things like run charts to be actually able to demonstrate improvement over time based on the interventions that were made was really important. And also, I think understanding that, you know, quality improvement should be embedded into our everyday work, and that they don't always have to be very large projects, that small projects can sometimes demonstrate, you know, a very significant improvement, which will have a positive impact on, you know, our patient and our staff outcomes. I think that was really apparent from our project, and we were delighted to see that.
Yeah, thanks, Emma. Catherine, same question.
I think for us, it was starting small, and just kind of working within one network was really important, because it ensured that we had the time to kind of review the results and then kind of implement changes before we kind of expanded the project. So I think that was my biggest learning from being involved.
Okay. And again, one of the viewers is wondering, you know, from the experience you've had, how can we harness the enthusiasm that we've seen in the videos from those who are delivering this work? How can we harness that enthusiasm, those who've completed the training, to roll out large-scale change across frontline health services? I suppose for each of you women, you know, what has helped you to harness this enthusiasm and I suppose the learning from the project? Evelyn?
Well, it's on our staff agenda at every meeting, and CHEs have project management training and have really embraced documenting our quality improvements.
Very good. So it's built into the infrastructure of the teams and the work. Very interesting. Emma?
I echo what Evelyn said there in terms of, you know, there's a lot of quality improvement work ongoing. And when we went looking to, I suppose, explore options for a project for this QI Collaborative, we came across some really fantastic work that was actually already ongoing that may not necessarily have been called quality improvement, but most certainly was. So I think it's really harnessing the passion that's already there in terms of improving, you know, quality and safety outcomes for everybody else in the service. And I think training is key to that, you know, for people to understand the basic QI tools that they can use to be able to demonstrate their improvements, I think is very important.
Yeah, great. Catherine?
I think for us, it was building on work that was already taking place. Like, we were already doing a lot of work within our services for older persons in relation to kind of falls and strengthening classes. So this was seen as a really nice addition and an essential addition to the services that we were providing. So I think that's how we managed to get such good buy-in.
Yeah, great. And Catherine, a follow-up question for you from one of the participants in relation to the physiotherapy referral pathways. Why was the starting point the acute hospitals as opposed to the primary care services, or was it?
Oh no, it was the primary care services. So these were all clients that had been referred to primary care. So this didn't start in.
Exactly. Okay. Yeah, I thought just for that clarifications. Thank you so much. And just to say to people, it's great you're already on sending in the questions. Remember, any questions we don't get to answer live, we will send the responses out to you. So keep them coming in. They're coming in hot and heavy, which is great. Huge participation today, over 350 people logged in, and your projects are really exciting. A huge amount of interest. So thank you to each of you for your work and for making care safer for all of us. Thank you so much, women. Really appreciate your participation.
Thank you.
The second set of videos we have today are all on the theme of drivers for improvement. We'll hear first from Dr. Philip Sheeran Purcell, a GP with the CHO 6 work on electronic referral pathway links. Then Julie Mannion, Siobhan Lynch and Mary Hurley from the Dental CHO Collaborative in improving recording of autoclave information within dental services in the Midwest. And finally, from Maeve O'Hare from Community Healthcare East, working with refugees and asylum seekers with HSC Wicklow. But let's begin with Dr. Sheeran Purcell.
Hello, colleagues. I'm delighted to be here representing our team from Wicklow. The team comprises James Glover, General Manager of Primary Care, Dawn Tyner, Community Healthcare Network Manager, and myself, Philip Sheeran Purcell, GP Lead for the network. Our network is centred around Wicklow Town and is the Community Healthcare East learning site in Wicklow. Our project, which we progressed under the auspices of the Royal College of Physicians in Ireland, Diploma in Leadership and Quality in Healthcare, is a HealthLink referral pathway between GP and primary care. The problem we identified was the existence of myriad referral pathways and the associated individual and different referral forms and paperwork that belong to each for GPs referring to the various disciplines in the primary healthcare network. Our aim, in line with SMART principles, was to introduce an electronic referral pathway between Wicklow GPs and initially two disciplines, that of physiotherapy and social work. This was to use the existing HealthLink referral pathway and be in place by September 2021. Our objectives were to provide a single clearinghouse, if you will, for the referrals. This will ensure consistency and safety in that any problem with the referral would be flagged immediately, higher quality of referral information and a reduction in error, and also time efficiencies for all concerned, and hopefully increased communication and awareness between the various therapeutic disciplines. We're happy to report that we achieved our target and went live in September 2021. As you can see, we started on a pilot and testing basis in my practice in July and August, and then opened physio and social work referrals to the other GPs in the network in September. To date, there have been 81 physio and 4 social worker referrals. I'm happy to report 100% delivery and 100% acknowledgement of these referrals so far. Podiatry and adult speech and language came online in November, hence their lower numbers. In working through the project, we found it helpful to focus on the importance of co-production and design and the involvement of the key stakeholders. There's been good buy-in from all concerned, and our next steps will focus on the further stages of the referral pathway, that is notification of the patient actually being seen and updates from the clinicians about the clinical course and outcome. This will enhance the patient's experience, improve cooperation between the healthcare professionals and foster further development. It also paves the way for multidisciplinary team and clinical team meetings. Thank you for your time and attention, and we welcome any questions.
We are delighted to present our CHO Collaborative project to you, the Sláintecare webinar, on our quality improvement journey in the Midwest Community Healthcare, led by our Primary Care Dental Department and our Quality Safety and Service Improvement Department. Our group consists of Mary Hurley, Senior Dental Surgeon, Siobhan Lynch, Dental Nurse, and Julie Mannion, Health and Safety Officer, QSSI.
Our problem statement was based on audit findings throughout a number of our dental clinics. Inconsistencies were identified in our implementation of infection prevention and control in relation to instrument sterilisation traceability. This led to our SMART aim, the standardisation of recording of autoclave information within dental clinics in the Midwest by Q4 of 2021. The reason why we have standards is to ensure a high quality, safe and effective dental service focused on patient safety and welfare. These infection prevention and control standards are regulated by the Dental Council Code of Practice and the National Oral Health Office Infection Prevention and Control Guidelines. It is the responsibility of every member of the dental team to adhere to these standards.
We realised our overall aim was too broad, so we decided to focus on the recording of sterilisation traceability information and completion of autoclave logbooks. This information was being recorded in different templates and focused on different elements in various clinics. We have two processes. The first process is pre-sterilisation, putting the correct information about each autoclave cycle on the gun label. This label then goes on to each sterilisation pack. The second process is post-sterilisation, filling in the record book which records the autoclave cycle information. This data must match the gun label and the automatic autoclaval cycle printout. The items to be recorded are number 1, the helix test, number 2, the automatic autoclave printout, number 3, the type of cycle recorded, number 4, the day of the week to be circled and the date inserted, number 5, the gun label, number 6, the number of bags in a cycle, and number 7, the signature of the person responsible. These items are where differences occurred in recording across different clinics. Resolving these differences was the focus of each PDSA cycle.
As well as using the run chart to track our progress, we also used the safety cross method for each month. The colour-coded system allowed us to visualise our improvements. As you can see, we started off in the red, where our gun label and record book information were both incorrect. But we have made the journey to green, and in September we can trace our amber days to annual leave and staff leave, which is even more of an incentive for us to continue with the rollout.
I just don't see it. I just don't see it. These were the words of one of our dental nurses during implementation of PDSA Cycle 3 that changed our approach to the problem. At each PDSA cycle, we had consulted with our colleagues and took action on any feedback given. It was during this one-to-one consultation for PDSA 3, by listening to the feedback and acknowledging the experience and advice of staff on the ground, we realised we needed a clear, simple solution to support staff through this change. Siobhan came up with a visualisation of what was required to be displayed as a staff prompt beside the autoclave. This visual prompt has been upgraded to our new poster. We hope to roll out this poster along with a single recording template to be used in all clinics in the Midwest. This will ensure consistency throughout.
Good afternoon, everyone. My name is Maeve O'Hare and I'm a primary care dentist in Community Healthcare East. In September 2019, my teammates Brenda Kenny, Kathleen Lynch and I commenced the Diploma in Leadership and Quality in Healthcare in RCPI. As part of our diploma, we undertook a quality improvement project entitled Signposting to Primary Care Services for Refugees and Asylum Seekers. The background to our QI project is that between autumn 2018 and spring 2019, 3 new centres were established in Wicklow to accommodate asylum seekers and refugees. Although primary care services are freely available, we identified that the children resident in these centres were not accessing dental and speech and language SLT services. Evidence suggests that the dental and SLT needs of this population are significant. However, it appears that there are many barriers to the uptake of care. Our smart aim was to ensure that 100% of children resident in the 3 centres who needed SLT and dental treatment were attending our services by June 2020. Here we have our run chart, which captures our project data over time. On the x-axis, we've collected data by month spanning from September 2019 to May 2020. The y-axis measures attendance to our clinics, and you can see in September 2019, only 10% of this population were attending our dental and SLT primary care services. Using Model for Improvement, Plan, Do, Study, Act, also known as PDSAs, we carried out 5 small changes of improvement, 3 of which resulted in increased attendance to our services, although 2 PDSAs failed to generate any results. Our first PDSA in October 2019 targeted the problem of lack of information about our services. To address this, our project team visited the 3 centres and distributed comprehensive information packs and leaflets to the residents. This test of change led to a modest increase in attendance. Our second PDSA in December 2019 addressed parents' concerns regarding their children missing school. We revisited the centres and offered appointment times during school holidays. This resulted in no further improvement in attendance. In February 2020, we enlisted the assistance of a local volunteer in Bray who works closely with the residents of the Emergency Accommodation Centre in the Esplanade Hotel. With her input, we co-produced our third PDSA, which resulted in additional attendance to our clinics. This was a positive move and directed us towards PDSA 4, which involved further co-production with volunteer groups connected with the Grand Hotel in Wicklow. Unfortunately, our fourth test of change in March was impacted by the onset of the pandemic and did not produce any increased attendance. As you can see on our run chart, the most significant improvement was our 5th PDSA. When COVID impacted our services in spring 2020, we switched to remote consultations by necessity, which resulted in significantly boosted attendance to our services, albeit on a virtual platform. Our 5th PDSA in May 2020 involved redirecting our attention to the Esplanade Hotel in Bray and working again with the local volunteer. With her input, the hotel residents were informed of the current availability of remote consultations. The parents of 40% of children engaged in this initiative, demonstrating that the use of this platform significantly boosted attendance to our services. To understand this result, we believe that some of the barriers which prevented residents from engaging our services in the conventional manner were overcome by using virtual consultation platforms. Barriers included difficulties in attending at the appointed times, problems with transport, cultural and language barriers, not knowing where HSE clinics were located, and reluctance to miss school. An important domain of our project was person-centred care with a focus on the what matters to me piece. We endeavoured to measure and overcome the potential barriers preventing this patient cohort from accessing our services. In so doing, we adopted a more bespoke, targeted approach to facilitating attendance, and we sought to empower and encourage active participation of this patient group in their own dental and SLT journey. Co-production and co-development with relevant stakeholders was crucial to maximise uptake of our services. Finally, I will leave you with a quote from W.E. Deming, the renowned forefather of quality improvement, which underpins the message that QI is a journey that we're all on together. Thank you.
And thank you again. I think you'll agree the diversity in the work that we're seeing, the different fields, the different areas, those last 3 projects, electronic referral pathways and GP primary care, dental health, safety, and finally then looking at improving primary healthcare services for refugees and asylum seekers, in particular for children. So really, really very various areas and very, very varied projects. We're delighted now to move into our second panel, and I'm joined by Dawn Tyner, CHN Manager at the CHO East South Wicklow. Julie Mannion from the is a Dental Health and Safety Officer, and Brenda Kenny is a Speech and Language Therapy Manager. So the three of you are very welcome and delighted to have you all with us this afternoon. Thank you, Brenda, you've joined us. So I guess the first question I would have is around, it's quite clear that you were using this testing of change ideas in the project's approach you were taking, plan, do, study, act, a kind of a cycle. What are the benefits of taking that approach from the experience you've had? Dawn, first of all, with your work, what were the benefits of this approach?
Thanks, Grania. I suppose from our perspective, when we started to look at a project, the PDSA cycle really helped us to take a large project and to break it down into bite-sized chunks. It also gave us an opportunity to test out our theory, put it into practice, and then come back and to adjust and adapt before we moved on. And really, as Philip mentioned, coming back to that co-design and co-production, so really thinking and speaking with our stakeholders and giving us an opportunity to see, is our theory and practice actually answering the questions that we had originally asked. So really supporting that integration and communication piece.
Very good. And just before I move on to your colleague, there's a question in specifically around the scalability of your project. Could it be rolled out to all networks across the country? And what resource is required to manage it? Is it an administrator role to manage referrals centrally? Asks Mairead Ahern, dietitian manager CHO7, who sends her kind regards.
Thank you very much. There's a couple of parts to that question. I suppose there is an opportunity. It depends on the platform that is decided upon from the implementation group. So there's a governance group there for community healthcare networks, and Alice McGinley's part of the conversation today would maybe be able to answer that. It's working in our area, it's being spread across other networks, but there may be other opportunities to trial different systems. There's two parts to any referral pathway. There's an administration part. I would never presume to
Yep, I've lost Dawn there. Okay, we can come back if she can get on. I'm afraid the gremlins are playing havoc with us this afternoon. Can I come on to Julie, looking at the project and the work that you've been doing, and again ask you that same question about the benefits of generating change through this testing change approach.
Yeah, I think from our perspective and our project group's perspective, like with the previous panelists, we came into the CHO Collaborative with a very big problem statement, and the PDSA cycle allowed us to break it down into a more achievable, smart, and approach it in a structured way. And by going through the PDSA cycle with our colleagues, it also ensured that it wasn't overwhelming, and ensured the changes that we made were taken on in smaller chunks, because we weren't overwhelming them with a massive change. We didn't just roll out, they were joined in every part of the process, they get their feedback. And I think that's particularly evident in the safety cross, where you see between PDSA cycle 3 and PDSA cycle 4, when the comment was made within the clinic where they just didn't see it.
Yeah.
They wanted a visualization, and by just listening and taking it in small chunks, it allowed us to ensure that cohesive approach led to the change being effective and of a higher quality.
Yeah, really simple, but actually the listening ear and finding out what were people saying and being able to respond to that. Thank you very much, Julie. Brenda, coming to yourself, and again, I think a really interesting project and the work that you're doing there. For you, the benefit of this generating change through a testing of ideas. Brenda, you're on mute there if you'd like to switch your microphone on. That's it. Yep.
Hi, thank you, Grania, for that. From our perspective, the Plan, Do, Study Act allowed us to test or change ideas in an iterative way. It allowed us to observe the changes over a rapid period and to engage in small tests of change where the capacity to fail or to not succeed was reduced. We also felt that the volunteers acting in the role of co-producers were an extremely important and integral part of our project in informing what our PDSAs would look like and how we would measure change through those PDSAs. I suppose the other thing was that we were dealing with the lived experience of those people, the residents of the direct provision centres and the temporary accommodation centres, in addressing their real life problems in signposting and accessing primary care services.
Yeah, and I thought it was very interesting, just the questions asking them. So people may be thinking, well, we don't want our children to miss school because that's really important to us. So not putting those up as barriers, saying, okay, well, can we do it at a time that it doesn't cut across your children's education? I just thought that was a really intelligent approach. There's a further question in here from one of our viewers, Brenda, for the project, and saying, well done on the dental and speech and language therapy services for asylum seekers, those in direct provision. Was there any learning from your project for other public services that might benefit from the learning you've had when trying to serve the needs of these populations?
Well, as I mentioned, Grania, the role of the volunteers who were a presence in the direct provision centres and the accommodation centres, and the residents had built up a trust in those people. So our using and collaborating with them was key to gaining their trust and ensuring that they felt the HCC was an accessible and trusted institution for them.
Exactly.
So that was absolutely key.
And I'm just wondering if part of the volunteer role, again, there's a question around, were you able to engage with the users in their own mother language, either through interpreters or in some other way? And if you did, was there a noticeable improvement in the engagement or appreciation of your efforts on behalf of the service users?
I mean, it's a really excellent question, and it's one we would have anticipated as being a potential barrier, and we're prepared to deal with that. But interestingly, the residents in general had a really proficient level of English fluency.
Okay.
But there was a facility, again, through the volunteers, that they would use a trusted relative or another person from their country to access the services.
Right, so in that way, building trust, but also through a trusted medium.
Yes.
Yeah, very good, very interesting. Has Dawn rejoined us? No.
Yes, sorry.
Oh, there you are. Okay, we missed you there. So we're looking then at the kind of second set of questions here around key lessons. I've asked this of the first panel, but I think it is an important question. The key lessons learned from your work, from engaging in this project work, key lessons for you and the services you provide.
Yes, I think it was the opportunity to develop the toolkit. So, to have, different tools at our disposal, then to be able to transfer the skills that we've used on this project into other projects, developing a support network even within the area. And I work with Brenda. I also work with Evelyn and Joanna. So, we have an opportunity now to share it across the whole CHO. And then I think building the engagement, communication, the trust, and that shared responsibility has been really positive. The opportunity to co-design from all sides, so engaging our GP partners in moving towards our acute services and across our disciplines, and then just really breaking down the fear around kind of tackling a project, so if we can see what we can achieve together.
Very good. And Don, there's a supplementary in from one of the viewers. Is there a new common referral form for the GP email referrals? And does it include all information that the physio or social welfare department require to be able to screen and prioritise?
Yes, so our project used the generic referral form on HealthLink. It's pre-populated from the GP's client information. It's a standard referral form, but there is a free text box then for them to add any additional information.
Okay, very good. Thank you for that. Coming to you then, Brenda, Julie, back to you around key lessons learned from your work in the project, from the engagement, key lessons.
Yeah, I think it was the cohesiveness and the use of our co-producers, the benefits of our people. You know, in community healthcare, there's a lot of benefits to multidisciplinary working. So not just keeping the problem in-house, so defined within the dental clinic. I was brought in from the Quality, Safety and Service Improvement Department, and using our resources and our people without there, because sometimes a different perspective can assist with helping finding clarity. And like that, like we used Gavin and Comms to help design our poster. Helen Angley, another dental nurse in another dental clinic in Limerick, came up with the template that we ended up using up and rolling out. And having access to our people and communicating with our people and taking that people-centered approach was probably the biggest lesson that we learned, and the benefits of it, because just our product ended up being of such high quality and so effective for us.
Very good. And often people use that people-centered as if we're only talking about the patients. But the way you're describing it, it's a much wider people-centered approach there. Other staff, other colleagues, other sets of skills right across that spectrum.
Exactly, Grania. We have a lot of skills in-house, particularly, you know, in the community healthcare. We've so many departments out there for advice, and it's just utilizing all of our skills. We can make such, like, even with our project, there was no massive funding, there was no massive cost. It was a little change with just people coming together and all thinking the same way and listening to one another.
Yeah, and yet the impact of it hugely beneficial. Brenda, coming back to you again, key lessons learned from the work. Just unmute yourself. There you go.
Hi, Grania, and thanks for that opportunity. So I suppose some of the learning Catherine and myself took from the course was instrumental in our work, in our redeployment to the community assessment hubs and to the testing centres during a significant amount of 2020. So we found the measurement tools, the PDSAs, the process maps, the stakeholder engagement piece was really useful as a means of bringing about small tests of change that really increase the efficiency of our work at the testing centres. Even simple things like signage for car parks, or small tests of change in the information being provided to the patients accessing the testing hubs and the assessment hubs. So yes, the learning from our course was really beneficial in that respect.
Super, thank you very much. And again, thank you to the three of you and your colleagues. Really interesting, diverse projects with great outcomes. So well done on the programme, but really well done on the application of some of those tools and testings and approaches that you came across on the programme, being able to bring them into your team and roll them out. Well done to all three of you, and thank you for joining us this afternoon. Our third and final pair of videos this afternoon are from Farron Lee in Cork and the Cork Kerry Community Healthcare CHO4. Firstly, let's hear from Anne-Marie Healy, Interim Assistant Director of Public Health Nursing at Carrigaline Primary Care Centre, and then from Elaine Harrington, Senior Physiotherapist. Over to Anne-Marie Healy first.
Good afternoon, everyone. My name is Anne-Marie Healy, ADPHN, Carrigaline Primary Care Centre and Network 13. The title of our project is The Person Behind the Wound. The other two members of our team are Pat Downey, GP Kinsale and GP Lead Network 13, Elizabeth Healy, Director Public Health Nursing, South Lee Public Health Nursing. The problem statement and SMART aim. The project team have ascertained that patients with chronic leg ulceration do not have a psychological evaluation as part of their current healthcare. The aim of this project was to ensure that 100% of patients referred to Carrigaline Primary Care Centre between January the 1st, 2021 to June 30, 2021 for the management of chronic leg ulcers have a psychological evaluation. This run chart shows the progress of our project. The percentage of assessments completed over a number of weeks and our change ideas are annotated as follows. The start of week 1, change idea 1, the introduction of a psychological evaluation using the hospital anxiety and depression tool, HADS, with patients. Following on from that, weeks 3 to 4, we focused on co-design and co-production. We used change idea 2 to assess the acceptability of the patient information leaflet. And in change idea 3 and 4, we checked the acceptability of the HADS tool and the process of administration with patients and staff. In this run chart, we looked at the time taken to apply HADS over a period of data collection. This is a balancing measure. Our staff narratives informed us that patients asked for questions to be repeated as they were familiar. We knew that this would take extra time, so we measured it. It did increase the time taken by 1 to 2 minutes initially, but as staff became familiar with the process, it decreased again. Person-centeredness. The patients and staff were central to this project. These speech bubbles demonstrate a powerful story. In change idea 2, we looked at co-design of the patient information leaflet. Here I interviewed a patient about its acceptability. He said, "As a wound patient for the past decade, I understand what is in the patient information leaflet. I think this wound project will be very helpful to people like myself." In change idea 4, I interviewed 2 staff who had administered the HADS a week previous. The following was a recurring theme. This nurse said, "I had to repeat at least 5 of the questions as the patients found the questions similar and they wanted to give the best answer." Another nurse said, "I am doing the dressing anyway and I know the patients very well, so I can find the right time to ask sensitive questions," referring to the HADS questions. Co-production. In change idea 3, my colleagues met with 4 patients to test the acceptability of the HADS tool and process. The time spent with the patients unearthed unexpected outcomes to inform this project as follows. The nurses are the best to ask the questions. "I don't mind when, except the worst thing is the pain. I suppose I wouldn't be listening to the nurse at all if the pain was bad. I wouldn't want anything like that," referring to a support group. "If I could get back driving just down to my sister, I would be happy with that." Another patient contributed, "I don't want anyone asking me questions except the nurses down here. I have no problem once I don't have pain. Once I have pain, there is no good in asking me about my head because the pain is too bad. I suppose the questions made me think. So I do get very depressed from being here in the house all day. There is one thing you never asked me. I get all the antibiotics and all the care, but the one thing that would really make me happy is if I could get out. I don't want online support or a support group. No, no, no." As a result of these narratives, our original idea that a support group would be suitable to all was not an option. During one of the narratives, this patient, Mr. T, who has a leg ulcer for the past decade, was heard by my colleague Pat communicating the following to the nurse in the dressing clinic. "I am allergic to silver in the dressings. The surfactant dressing doesn't work. What about the hydrocolloid dressing today?" This is co-production in action. Finally, as a team, we had significant learning from this project. We strongly recommend investing time in co-design and co-production, as there is nothing about me without me, which is a key philosophy of person-centered care. This project is currently engaging with the patients who had high HADS scores to co-produce suitable referral pathways. In addition, the study suggests a need to also consider psychological distress in the context of chronic disease management. Thank you for listening.
Hello, my name is Elaine Harrington. I'm a senior physiotherapist, and together with my occupational therapy colleague Fiona McMorrow, we work in Farranlee Community Nursing Unit in Cork. Our project was to enhance residential care activities through a collaboration between physiotherapy, occupational therapy, activities team and residents to promote positive ageing for residents in a CNU. We know that positive ageing should be promoted in residential care. However, we see that residents are inactive and unoccupied for long periods of time. We know that inactivity can decrease function and affect mood, and there's strong evidence to report that physical activity and engagement in meaningful activity can support and maintain positive ageing and well-being. We plan to explore creative and innovative ways to look at how we can work better as a team, and our SMART aim was to increase and sustain attendance of residents to group activities with allied health professional involvement from 0 to 30 contacts per week by the 30th of July 2021. The run chart here illustrates our progress to date. This is a novel way of incorporating physio and OT prescribed programs into regular activity programs in CNUs. Residents had targeted interventions based on their physical, cognitive and social abilities and interest. Residents attended had an additional 60 minutes of physical activity built into each week, and they created window boxes for every resident's room through this project. The run chart here shows that we successfully completed 2 blocks of activities, one gardening and exercise and fun dance group between May and August 21, and we did another block of gardening in November. We achieved the target of our SMART goal of 30 attendances per week on 4 occasions. We did regular tests on changes implemented during this time to explore ways to optimise attendance and engagement. This included planning and feedback sessions with activity staff, ward staff and residents, and some reasons for the low attendance included competing staff work demands, overlap with scheduled family visiting times, and fluctuating frailty levels of the residents. Our plan to review and recommence after annual leave in August was altered by some unexpected staff sick leave, and it was November before we could reintroduce the gardening group again. Our most recent test of change is leading us in the direction of sustaining this project by bringing more staff on board. We have looked at balancing measures such as the impact on number of falls and challenging behaviours, but to date there's no correlation seen. And also, as the physio and OT here are sole practitioners in this setting, we've had to be flexible and adapt how our usual service is being delivered. For this co-production to succeed, we use cognitive and communication strategies to support and optimise the residents' engagement in the feedback and planning sessions. To capture their experience and accommodate for memory impairment, we recorded their words during sessions. Feedback and acknowledgement sessions with the residents were supported with visual prompts by using slideshow photos taken through the activities. A rich body of valuable words of the residents' experience was displayed around the unit in word clouds, along with photos to support conversations with staff and families. Photos were sent to families during sessions also, and we facilitated video calls to family members during some of the lockdown sessions. This helped with social connectedness between loved ones and reduced some of the anxiety associated with the loneliness and isolation of lockdown. The striking thing to us as facilitators in this is how the residents valued the work aspect of the gardening in particular. The motivation to get up and complete work showed us physical and cognitive skills that we had not seen them tap into before. We observed natural chats they had between themselves, camaraderie and helping each other out. None of us facilitators are in any way expert gardeners. Some of the residents' attendees were new to gardening also. But we all learned from the expertise that was within a few of our residents who are gardening enthusiasts. The word cloud here illustrates the gardening feedback. Phrases that stood out for me: this reminds me of gardening at home. It's lovely to tell family and friends what I'm doing. Time just flies when I'm gardening. And it's fun, but it's work. This project has been a resounding success with the residents and their families. They've a clear preference of this new way of working together, and their feedback has given us ideas for future sessions. We couldn't have done this without support and supplies donated from families, staff and local businesses. And a huge thank you to the residents for their enthusiastic participation, to the Farranlee Road management and staff, and to the HSE and RCPI faculty for helping us to achieve this.
So again, two very different projects, but certainly a co-production, very clear with the service users. I'm joined now by our final panel for this afternoon. I'm delighted to have Fiona McMorrow, whom you've just heard from on the panel, Senior Occupational Therapist. Fiona, you're very welcome. And Dr. Pat Downey from the person behind the wound chronic leg ulcer project. We also have Dr. John Brennan rejoining us from the RCPI. From Sláintecare and the Department of Health, we have Muriel Farrell with us today. And also we're joined by Alice McGinley, who's Head of Service Community Healthcare Network Implementation Lead at the HSE. But first, back to the project developers, to Pat and Fiona. And again, looking at, how did you find this process of designing change with those who are using a service? What were the key challenges and the benefits of taking this approach? To you first, maybe, Pat.
I suppose from, thank you, Grania. From a GP perspective, I think, well, as GPs, we're in a position to establish deep relationships with our patients. We see them a lot, especially our elderly patients. And there's strong evidence of better outcomes when a clinician is providing continuity of care, and he or she knows her patient well, or knows the patient well. And I suspect what we're talking about here, the co-design and co-production, I mean, I'm thinking that that's probably something that's part of our practice, but really we kind of hadn't a name for it before, if you know what I mean.
Yeah.
And I suppose the course put a bit of structure to and it got me certainly thinking about the way I interact with my own patients. Now, with the project that we were doing, these were patients these would have been patients with other GPs as well. But I wouldn't have known them. But being able to apply the principles of co-design and co-production certainly helped me understand what that was about. And I suppose it's kind of, the process of co-design and co-production kind of became clearer to me as our project evolved, because our project did change. Initially, we had quite a big plan. We had to really narrow our focus to exercise the PDSA cycles and make those incremental improvements that result in a greater improvement. So I would say very it certainly helped me in terms of the way I practice personally. And I was grateful for the opportunity of doing that course.
Yeah, very interesting. And again, we're hearing over and over that the narrowing down and the focus, we go in with these ideas and we'll do the divil and all, but actually it's the focus that sometimes gives that fine-honed thinking, allowing you to do the correct thing in the correct manner. There's a question came in, Pat, specifically to you, asking, was either the additional psychological service and the information leaflet available bilingually or in Irish and offered to the patient? Apparently this is a legal requirement moving forward following the enactment of the new Official Languages Act.
The short answer is no, I'm afraid.
Fair play.
Our psychologist is South African, so we would have had some difficulty there.
It wouldn't be much help to them. But again, I think it's another example maybe of the kinds of demands that are being made of services and having to build those in as we go forward. Thanks very much, Dr. Downey. Fiona, coming back to yourself, I was very taken with some of the, the statements there. It's fun, but it's work. I mean, that just moved me. I thought that was beautiful. And people saying it's just like gardening at home. And that whole thing of moving towards, you know, that experience, which is very different maybe to our collective understanding of, you know, congregated care and your attempt at what is moving towards a more positive aging model. But again, for you, Fiona, the process of and we could see the co-designing. What were the challenges and the benefits of taking that approach?
Okay, thanks, Grania. I guess for us, it's probably one of the significant challenges were that this cohort of residents, or a portion of them, would have had attention and memory problems. So working with our activity colleagues, you know, we used a lot of cognitive and communication strategies, you know, such as maybe visual cues, to look at maybe how we could optimize their engagement in the feedback and planning sessions. I guess the other thing that we probably did was that, you know, we really, during the activities, we captured their comments, you know, we recorded their comments, you know. So, and I guess we did a whole range of other things. I think in our feedback sessions, you know, because it was this kind of age profile, you know, we really wanted them to feel welcome and at ease in these sessions. So, you know, I guess we took the good china out, we gave them a cup of tea, all those little things probably made a difference, Grania.
Yeah, no, I can see that. And I think some of those. Go on.
And I guess just to finish, apologies, just in terms of the benefits have been huge. I guess, you know, as we've seen a big improvement in residents' engagement, you know, just listening and taking on board their feedback has really helped us to provide a better kind of person-centered service. And I guess what we see is this kind of lasting experience, you know, where families are giving much more, you know, are giving positive feedback on it.
Yeah.
And I guess it's also improved team working, you know, it's you know, so look, we plan on, you know, using this kind of collaborative co-production work in other projects now, taking it into other parts of our practice.
Fantastic. Thanks very much. And a lovely comment in. Wonderful to see older residents derive such joy from gardening. Very interesting insights from speaking to wound patients about their mental health in a safe space with their nurses too. Incredibly inspiring work. Co-gorgeous Ó Cree live. Well done to all. Isn't that just lovely? And what a lovely transition to the wider panel of guests that we have with us this afternoon, moving from the very particular and very specific work of all the projects back to the wider view. And I'm sure, John, your heart must be bursting with pride at having witnessed all of those projects and their various but really lovely and some of them very moving presentations. So we'll welcome back now the other panel members. So John, overall, what do the RCPI program seek to achieve? And from what we've seen today, are you doing it? Just, you're on mute there, John.
I said, I suppose you tell me, Grania, and maybe
I think you are, but I'd like to hear you say
maybe the viewers can as well. I mean, you know, there's only one big goal, and that's improve the quality and safety of care, you know, and outcomes for patients. That's the only goal. I mean, there's lots of kind of sub goals or objectives to help us sort of get there. I mean, as you've seen from the projects, like, you know, everyone on here is doing this on top of their already very busy job. You know, we can be thankful to HSE Primary Care and HSE Quality and Patient Safety for creating this space or creating this forum and creating the opportunity for people to come on these programs. But these people working on the front lines, you know, all of these, you know, talented and incredible professionals, they're bringing the ideas, they're bringing the will. All we do is kind of help to try and shape that execution to make it as efficient and impactful as it can be. You know, that's our goal here. We facilitate, we direct the energy, you know, I think for me, for our programs, what we're really trying to do is, you know, enable, equip, and above all else, empower. You know, the most important resource we have in healthcare, the people, to be able to do a better best every time they want to try and do that.
Yeah, very good, very good. Better best, I like that. I was struck by many of the comments from patients, but I was particularly struck by some of your patients, Dr. Downey, you know, saying, you know, if I could just get out, if I could just get back into the car to drive down to see my sister. I mean, that catches me when I think about that. That's the kind of difference in the quality of life that some of these interventions, real differences for people in the quality of life. So yeah, I must say I've been very taken and moved and really impressed by the work that we've seen today. I see Catherine Healy sending in a comment. Thanks to the two Johns and all the staff at the RCPI and the HSC for funding the quality improvement diplomas, the support staff to work together in teams with their clients. Thank you for that. Muriel, can I come to Muriel Farrell now, a stranger to nobody on the call here today. Muriel has been deeply involved in the delivery of Sláintecare, managing the Sláintecare Implementation Fund projects over the last number of years and from within the Department of Health. Muriel, can I come to you from a Sláintecare perspective? How does the participation of colleagues on this type of programme contribute to the actual delivery of Sláintecare?
Thanks, Grania, and I share your passion and energy for all these projects today. It was really, really brilliant looking at them all and the work they've done. And interestingly, you know, no significant investment required, just people using their, you know, using the knowledge and the experience that they have and their working relationships. So again, I'd like to say a big congratulations to the participants on the program. And, you know, the fact that they have so many competing priorities, particularly in the last year and a half, well done to you all for completing the program. And look, as leaders, it's really important that we take that time to reflect and enhance our leadership style and our practice and our techniques, so we can empower and inspire our own teams and colleagues in the future delivery of health services. And I'm sure you will all agree that the multidisciplinary nature of this leadership development program is particularly valuable, as it provides an opportunity for you to gain insight into the unique role and the contribution of each member of the multidisciplinary team, because most of you work as multidisciplinary teams on the front line. And I expect that this is a professional network, and no doubt that will serve you well as you move through your career in public health services. The working relationships that you've built in this network are just invaluable. In terms of implementing Sláintecare, through this RCPI development program, as you said, you know, the HSE are investing in participants as leaders who actually hold key roles in the implementation of a key Sláintecare priority, and that is to shift care to the community where appropriate. And that's been done through the Enhanced Community Care Programme, which no doubt Alice may refer to as well. And the rollout of that programme involves the introduction of the community health networks and the integrated care programme for chronic management of chronic disease and older persons, which I know you're all involved in. And then more specifically, the QI methodology, which is an important part of this programme, focuses on improving the patient experience. And we've seen patients at the centre of all these projects. And this is a fundamental goal of Sláintecare and underpins all of our actions, patient-centred care. And Sláintecare also promotes, and I love hearing people talking about this, working collaboratively in the co-design of the future with all stakeholders, building on what works well in the system, because there's an awful lot of things we do well in the system, and identifying then opportunities to redesign the elements of the care process or care pathways to improve patient care. And as we know, frontline healthcare workers are one of our greatest resources. And you know where the improvements are and where changes can be implemented. And through your participation in this programme, you will be supported now in your approach to service improvement using this QI methodology. I think somebody mentioned like it's a framework for having those conversations. That. Other key strengths then of the QI methodology, which align to Sláintecare, obviously, is the emphasis on demonstrating evidence of improvement through outcomes. And as you say, Grania, some of those outcome measures are really simple outcome measures, but important for people. And then there's the other end of the spectrum in terms of those. And then finally, the QI methodology supports the creation of a learning culture, which is very important. And this provides a safe space to test and try new ways of working, accepting the achievements and also the learning equally. And this is very important for informing policymakers and decision makers about innovative ways of meeting citizens' needs, setting the priorities, and of course, allocating resources. So again, congratulations on the improvements achieved, and we look forward to hearing more about future success and learning from the knowledge and the new techniques that you've acquired on this programme. Well done.
Thanks for that, Muriel. Thank you. And Angela sends in a comment, feeling truly inspired by the very diverse initiatives. When is the next course? I have an idea for my project already. Angela, God loves a trier, and fair play to you for getting in. So we might get John to tell us when is the next course, and we'll actually publish it in the Q&A. That's super. Our final guest this afternoon, but by no means of least importance, is Alice McGinley. And Alice is, as I've already said, from the HSE. And Alice's role in the HSE is as Head of Service, Community Healthcare Network Implementation Lead. Alice, you're very welcome. Alice, would you tell me about the importance of quality improvement to patient-centred care, and perhaps just some short reflection on some of the projects that you've seen presented here this afternoon?
Good afternoon, everybody. Good afternoon, Grania. At the outset, just to congratulate all of the participants on the wide variety of projects that have been presented here today. And as has been acknowledged by other speakers, these projects have been done in addition to the day job. So it just shows the leadership and the enthusiasm that is out there in terms of patient care. It's a really exciting time to be employed in the HSE. I'm looking at your banner there throughout the presentation, the right care, right place, right time. And I just refer back to John's introduction in relation to quality. Again, it's around timely, efficient, effective, patient-centred. So we all have the same quality improvement. It underpins all of our strategies. In the HSE at this time, for those of you who may not be aware, we speak a lot about the Enhanced Community Care Programme, which really is the implementation of Sláintecare, the setting up of community healthcare networks at local populations of about 50,000, and then the community specialist teams for older people and chronic disease, and a big focus on integration with our acute colleagues and integration amongst ourselves as teams. Within all of this, I suppose it's really, really important to keep everybody safe, to keep staff safe, to keep the service users and patients safe. As part of the overall funded project, there is an additional 3,500 new staff coming into the system. So when you're in a change process, it is really, really important that you put quality improvement plans in place to ensure safe care at all times. I think some of the tools and learnings and insights that we've heard today will significantly help everybody in terms of stakeholder engagement and in terms of small projects that can be taken on that will actually inform larger pieces. So if I refer back to the referral pathway that Dawn spoke about, and Philip, that will really inform us as we move forward into the centralised referral. Also, I suppose what is really important is that the outcomes for the service user, we have better experiences and better outcomes. And I think we touched on some of the experiences, like was said about the leg ulcers and person just wanting to get into the car. In relation to staff, I suppose we have a focus now on the health and well-being of staff. That's really important if we want to be the employer of choice, and to recruit and retain new qualified staff, we have to have this focus on quality improvement, a learning organisation and supporting staff. And I suppose really it's just, again, to congratulate everybody. There is a huge amount of work to be done, but I think with the enthusiasm and the small pieces, we certainly would be on a journey of getting to where we want to change the overall focus in a big transformation programme. So thanks very much to everybody, and certainly a lot of the elements that we've discussed today and the tools around plan, do, study, and act, that is going to be central to everything we do, and our stakeholder engagement piece at all levels. So thanks very much again to everybody, and thanks for a very informative session this afternoon.
Thanks, Alice. Thanks so much for being with us. We really appreciate it. So for those of you who have an idea, great to hear about the interest. Keep an eye on rcpi.ie for upcoming courses and opportunities. You can follow them on @rcpi_QI on Twitter and other social media platforms, or you can register your interest in a QI program by going to qualityimprovement@rcpi.ie. So there you are. If you have the ideas, John and his programs are waiting for you to contact them, and you can be like some of our other champions. And I do think everyone who presented today is a real champion of both the principles and the practice that we've seen over the last 18 months in Sláintecare and beyond. So look, we've had a really packed program this afternoon. It was a real pleasure for me to showcase the work of those who've been engaged in the RCPI Diploma in Leadership and Quality in Healthcare. Lots of positive outcomes for patients, improvements in care systems and efficiencies, and enhancements on show right throughout the excellent work. I want to thank each of our guests here today, all of our panelists and those who featured in the videos. I want to say thanks to all of the team here who helped to produce the session: Rosaline Harlan, Muriel Farrell, Kira Eustace, Lindsay Dre, Erica Kinsella, Nicole Kyohan, and Tom Duke. I want to in particular thank all of the projects who went to the trouble of producing videos. The time and effort it takes to produce a 5-minute video, if you've had to do it, you'll know the effort it takes. 20 minutes is no problem, but 5 minutes, that's the challenge. So well done on those of you who were involved in managing and keeping people who have so much expertise and knowledge to a 5-minute slot. Well done. So you can watch the webinar back or recommend it to your colleagues. It will be available on the Sláintecare website. So from me, Gráinne Healy, thank you so much. Continue to stay safe, everyone. Have a very good evening.